ايش؟
الموبايل حتى اقدر اتحرك. الو. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. في البداية أقدم لكم التهنئة لنجاحكم إلى سنة رابعة، وأنا تابعتكم من سنة ثانية. إن شاء الله هذه مرحلة جديدة تبدأون فيها الكلينيكال training, which is the core knowledge that you will acquire to be a doctor, to be doctors. As part of the internal medicine, the clinical skills and communications that we are going to start today belongs to medicine. Other disciplines also will share in the subject, in the clinical skills and communications. Today we'll deal with the respiratory tract. We have two sessions. The first session will deal with taking history. So the first lecture will deal with taking history. The second lecture we will have a break, a shorter break, and then we'll come back to talk about a clinical examination of the respiratory tract. The learning objectives, part 1 and part 2. Part 1, taking comprehensive history, comprehensive كامل شامل for the respiratory diseases. So we will have a broad discussion about varieties of respiratory diseases. So don't panic as it is too much knowledge. No, it's just a sort of massive, broad identification of certain diseases. You will have these diseases systematically, and you will be aware about them. But just to make you oriented how to take history, we have to mention these diseases. The second point, when you ask a question, why do you ask this question? You give reasons, scientific background for asking a question. When you ask the question, have you got a cough? It means there is a reason, background for it. Part 2 will show the details of a clinical examination for the respiratory tract. I will discuss it to you with pictures, and then next week, inshallah, we will see a video session. We will have a video session about respiratory tract, and you will see what I have talked about. And then, of course, after that, you will have the skill lab training for 2 weeks, and you will be familiar with all what you have heard as a knowledge. Now, again, for the clinical examination, we have to give explanation why we are doing these maneuvers, why we are doing these tests, for what, to identify what, to detect what. So we are going to give reasons for the maneuvers that we are going to do. So starting with part 1, taking history. Now, history taking in respiratory diseases. This is devoted, although there are overlaps with other systems, with the gastrointestinal, with the endocrine, and other. But regarding the respiratory system, what we are going to talk about the history for the respiratory tract. Taking history and doing a clinical examination are to be learned. You have to be taught about them and practice them. I advise you, when you are going to finish this lecture today, when you go home, practice them with yourself, with a friend, with a member of your family. You will get a training and gradually will be familiar with them. As much as you do learning, you will be more familiar with the clinical examination and history taking. The important thing in history taking is the patient, is the cornerstone, is the source of the information. أهم إشي بالنسبة لنا المريض، مصدر المعلومات. So we have to learn how to take history from the patient. Taking history, 70% of the diseases can be diagnosed by taking history. 20% more by clinical examination. So, taking history and the clinical examination, 90% of the diseases can be diagnosed. Laboratory tests and other investigation like imaging and others, 10%. Now, for the laboratory test, if the test is highly specific and highly sensitive, that is to say, SS sensitivity of the test, SP specificity, okay? If these tests are 90 to 99% sensitive and specific, only 1/10, that is to say 10% only of the tests that you are going to request are positive. Only 10%. So don't depend so much on tests and requesting tests. Depend on your history taking and the clinical examination. This is the classical medicine. Although unfortunately nowadays is not practiced this way. Now, for any symptom, I am going to give you bases, just broad lines, just to stick them in your mind, and you will build up your knowledge later on about them. Finding the underlying cause for any symptom. If a patient say to you, I have got pain in my lateral side of the chest, you have to find the underlying cause for the pain, and so forth, by taking history, of course, and then a clinical examination. One thing I would like to advise you, when you go to hospitals and to the clinical rounds, you have to have a respectable image. واحد لابس كويس، لأنه the patient will look at you as a doctor, not a student. So you have to have a respectable image, so you will be respected by the patients and the staff, the supporting staff, like nurses, for example. Always, first of all, when you are going to take history from any patient, introduce yourself. And tell the patient you are fourth-year medical student and you ask for a permission to take history and to do clinical examination. Without introducing yourself, you will find this in the OSCE examination. You will have OSCE examination, all right? And we will see whether you are going to introduce yourself to the patient or not. Say your name, I am so-and-so, I am medical student. Would you allow me to examine you, please? and take history from you? So the patient will say to you, of course, yes, and then you can start your job. You have to respect the privacy of the patient. It's not allowed that you will take off the clothes of the patient in front of many people. You have to respect this, especially in our community for the females. You cannot examine any female from now on, all of you. From now on, you cannot examine any female without the presence of a companion. The companion is called chaperone, and it should be female chaperone, female companion, for the respect of the patient. And you have to take all the measure to respect our community and the tradition in examining any female. When you are a group and taking history from a patient, one student only should take the history. It's not allowed that many students will share in asking a question. This is not allowed. And you cannot correct your student, your colleague, while he or she is taking history. Stay silent until your friend finish, and then you can correct anything that you would like to correct. But do not interrupt your colleague. These are basic things. I am teaching you basic things that you will apply soon in the hospitals. After completion of taking history, you can correct your student. You can ask him to ask another question, which is not clear to you. One important thing, to give enough time for the patient to express himself. It's not allowed that you interrupt the patient. He is talking during half a sentence, and then you interrupt the patient. The patient will be disturbed, as if you are not hearing him or her, right? So give a good time for the patient to express his symptoms to you and his concerns. But if the patient is talkative, some of the patients are talkative, talks quite a lot. So you have to stop the patient tactically, بأدب, بلباقة, بدبلوماسية. You have to interrupt him, and then you can go with him. If the patient is depressed, does not want to talk, you as a doctor or a trainee, you have to encourage the patient to talk. This is your responsibility. Sometimes they bring to you in examinations difficult patients to see your ability, whether you can interrogate such a patient or not. So you have to be able to interrogate any patient. Now, if the patient asks you a question and you don't know that question, it's not embarrassing to say, I don't know. I will ask for you and let you know. Okay? So, history taking is intellectual medical interaction between you and the patient. Now, if the patient asks you relevant question, it seems that such a question, you have to know it. And you are not remembering the answer instantly at the moment. You will say, I will tell you later. As if you are taking your time to think about it and then to tell the patient the answer later on. In respiratory tract, it is differentiated into upper respiratory tract and lower respiratory tract. And we have taught you these things during your preclinical study. Larynx is the dividing area between upper and lower, and I will show you a picture. Lower respiratory tract is usually sterile, while upper respiratory tract is not. Example of diseases of upper respiratory tract: rhinitis. You know rhinitis, inflammation of the nose. All right. Sinusitis, التهاب الجيوب الأنفية. Pharyngitis, التهاب الحلق, البلعوم. And epiglottitis, inflammation of the epiglottis, لسان المزمار. Lower respiratory tract diseases, examples: tracheitis, inflammation of the trachea, bronchitis, pneumonia. All right? We have to know certain landmarks for a clinical examination. For example, angle of Lewis is the junction between the manubrium sterni and the body of the sternum. Okay, so it is called angle of Lewis, where the second rib bind to the sternum. So it's a landmark. If I tell you second intercostal space, so you should know the angle of Lewis, mark the second rib, below it the second intercostal space. Now, at this area, at the angle of Lewis, is the bifurcation of the trachea, right and left. So, good mark. You have to know that the first rib is under the clavicle. If I ask you to examine the first rib, you will say, no, I cannot examine it, because it is under the clavicle. And then we will come to this point. The tip of the scapula from the back, the tip of the scapula, it corresponds to the seventh intercostal space. And we will come to this point. Is very important when we are going to examine the chest clinically from the back. So remember, seventh intercostal space, the tip of the scapula from the back of the chest. You can see the upper respiratory tract, nasal cavity, okay? The nasal cavity, pharynx, and larynx. Lower respiratory tract, so the larynx is part of the upper, right? Lower start from the trachea, then a bronchi, then the lungs. So it should be clear to you, although this is basic knowledge, but we have to repeat it to you. There are certain marks, as I said, which we have to depend on them. This is the sternum. This is the midline, okay? السلايد اللي قبلي العفو. لا قبلي تمام عين. We have the mid-sternal line the mid-sternal line in the middle, and then the mid-clavicular line. The mid-clavicular line, from the name you will understand it, is the midline between the sternoclavicular junction to the acromioclavicular joint, right? So midline is the mid-clavicular line. Anterior axillary line, you can see here a note that the sternal angle, also known as angle of Lewis, sometimes it's called sternal angle, or manubriosterni junction, as I said, and we have explained it. The anterior axillary line, it corresponds to the midline between the mid-clavicular line and the lateral end of the clavicle. يعني الوسط ما بين وسط الكلافيكل والlateral end of the clavicle هذه anterior axillary line, which correspond to the anterior axillary fold. يعني هذه طية الأبط، هذه anterior axillary line. The posterior correspond to the posterior axillary fold. So these are the important points. The sternal angle or angle of Lewis correspond, as I said, to the second intercostal, cartilage and rib. One thing here I will show it to you later regarding the lobes of the lungs. Mid-clavicular line, we have explained it. Upper lobe examination. Upper lobe examination should be done from the front. When you examine, whether by palpation or auscultation, later on we will come, it should be from the front. You know the right lung has 3 lobes, upper, middle, and lower. The left lung has 2 lobes only, upper and lower. So upper lobe from the front. Middle lobe in the right can be examined from the front. From the back, we have to examine the lower lobes of both lungs. Why not the upper? Because it is covered by the scapula. Yes? So it should be clear to you this way. If you would like to examine the whole lung, upper, middle, lower, for the right, you have to examine it from the lateral side. It will show you the 3 lobes from the lateral side. And that is why in surgical operations, usually done from the lateral side. You will see the incision. During examination, you have to examine the lateral side of the chest to see whether the patient has got a scar of an operation on the lungs. Where do you see the scar? Usually on the lateral side, extending to the back of the patient. Also, I will show you a picture for it. Now, what are the major symptoms of upper? Look, here the U is of different colors, of the upper respiratory tract. The major symptoms, first of all, nasal obstruction. Ask the patient or the mother if the patient is a child about nasal obstruction. How is it started? Is it unilateral or bilateral? In children, unilateral obstruction it may indicate for you foreign body. You know, children, they put sometimes foreign bodies in their nose during playing. So when you have unilateral in a child, think about foreign body. And ask about nasal obstruction, whether it is continuous or intermittent. And this, if the nasal obstruction is associated with symptoms or discharge. So you have to be familiar with these questions. During OSCE examination, sometimes during stress of the student, some students forget these relative questions. You have to train yourself and ask these questions repeatedly until you master them. The other point, nasal discharge. Here it can give you a clue about the underlying condition. For example, if the discharge is greenish or yellowish, it may indicate, or pus sometimes, may indicate infection. Correct? So, if purulent, infection. If watery, remember this, especially in children or in accident, if watery discharge, it may indicate CSF, a dribbling, maybe a fracture of the base of the skull. So remember these points. May be vital. If you miss it here, if you miss that this is CSF, the patient may go into serious complication and may die if you do not recognize this. Now we come to epistaxis, الرعاف, دم من الأنف يعني. You have to remember you have to differentiate between epistaxis, hemoptysis, hematemesis, okay? So epistaxis ask about the amount of the blood. Is it whole blood? Is it streaks of blood? يعني خطوط هيك يعني نقط أو خيوط of blood with the discharge. Ask whether the patient had a trauma or not, because commonly epistaxis may be due to trauma. واحد ساقط ده يلعب كرة قدم اجت ضربة على الأنف إلى آخره. So these are common causes for epistaxis. Sneezing. As I said, in children, when they have foreign body, they may get sneezing, as if the body wants to get rid of the foreign body by sneezing. Sore throat may indicate infection. Hoarseness of the voice. هذا بعده هو نفسه. Hoarseness of the voice, بحة في الصوت. مهم هذا السؤال, especially in elderly people. Many causes for it. Infection in young people, in adolescents, may be due to laryngitis, epiglottitis, pharyngitis. These are the common causes of hoarseness of the voice. But in elderly, it may indicate carcinoma of the larynx, right? And also in heavy smokers. In heavy smokers, when they get hoarseness of the voice, بحة في الصوت, it may indicate left lung cancer. Why left lung cancer? Because the left laryngeal nerve goes down to the lung and then come back to the vocal cords, while the right recurrent laryngeal nerves come directly to the right vocal cords. أعيدها مرة ثانية. الليفت ياخذ له لفة باللنج وبعدين يجي للvocal cords. الرايت لا يجي directly. So sometimes there is a tumor called Pancoast tumor of the upper lobe of the left lung may be there, which compress the nerve and cause hoarseness of the voice. There is another thing called stridor. Occur with the upper respiratory tract diseases. stridors يعني علامة الاختناق. واحد دا يختنق بهالشكل. Okay? علامة الاختناق. And we will see the details in a moment. Now we come to the major symptoms of the lower respiratory tract. The major symptom, first of all, cough. It's a major symptom. Usually the cough is explosive. Why explosive? Because intrathoracic pressure is up to 300 millimeter mercury, and the expiratory velocity of the cough may reach to about 500 miles per hour. Very high pressure and very high velocity. In bronchiectasis, توسع حويصلات الرئة, dilatation of the alveoli. It's called the bronchiectasis. وراح ناخذ هذا المرض بالتفصيل إن شاء الله معاكم. Usually there are a lot of secretions accumulated in the lung, which may cause obstruction. So encourage the patient with the bronchiectasis to cough. Encourage him, right? The cough, as a background, we said we have to know the background. There are sensory receptors from the alveoli to the nose, which may get stimulated by different substances like dust, acid, or ACE inhibitor, angiotensin converting enzyme inhibitors. So you remember, when a patient comes to you saying, I have got a cough, ask him about ACE, and he may say to you, yes, last month I have started one of the ACE. So you have to stop such a drug, which is causing cough in some patients, not all patients. For the cough, what are the relevant questions you have to ask? If a patient has got a cough, what you are to ask him? About the onset, about the duration. مهمة هاي الأسئلة. Whether it is dry or productive. قحة يابسة لو بها discharge. مهم هذا السؤال لأنه يعني لنا الكثير. Diurnal variation, is it at night? Is it during the day? Is it during the work? It may be occupational, right? What are the aggravating factors? What are the precipitating factors? What are the relieving factors? All these you have to ask them. For example, I give you a few examples. These examples, don't be confused with them. These are just examples, and you will learn about them gradually during your course. But just to make you oriented, why we are asking these questions. For example, at night, cough at night may indicate asthma, الربو. In elderly paroxysmal nocturnal dyspnea, which may indicate heart failure, left ventricular failure, or congestive heart failure. Seasonal, يقول لك والله بس بالربيع, allergy. Now, if the cough is present for less than 3 weeks, it is called acute. If it is more than 8 weeks, it's a chronic cough. Examples of diseases causing a chronic cough: asthma, chronic bronchitis, lung cancer. These are just examples. Tuberculosis. All right. As we said, at night, it may indicate asthma. Also may indicate paroxysmal nocturnal dyspnea, PND, which indicates, as I said, left ventricular failure or congestive heart failure. Chronic bronchitis. In chronic bronchitis, واحد عنده chronic bronchitis will have repeated cough. النهار كله وبالليل بيقح, خاصة السموكرز. Sometimes you have to put a differential diagnosis for the cough. It's not always due to the respiratory tract. It may be related to the esophagus. There is a disease or condition called reflux esophagitis. بيرجع الطعام على المرئ. The disease is called GERD, gastroesophageal reflux disease. So the vagus nerve will get stimulated, and the vagus will stimulate the cough center. Remember, if the patient coughs repeatedly for some time, he may get cough syncope. يغمى عليه. Remember, cough syncope by repetitive cough, such as in chronic bronchitis. The mechanism of the cough, I will explain it to you in summary. Many causes or many diseases can cause cough. As I said, remember occupational cough. Some people get it during work due to allergic conditions. واحد يشتغل في معامل النسيج, من يروح الشغل شو معناتها؟ معناتها due to the fibers of the textile may get allergy. The cough reflexes, just a background, is not that important to us. There are receptors and effectors. The receptors اللي تجمع الأحاسيس: trigeminal nerve from the nose and sinuses, a glossopharyngeal nerve from the posterior pharynx, a phrenic nerve from the pericardium and diaphragm, and the vagus nerve from the ear canals, eardrums, trachea, bronchi, esophagus, stomach, pleura. These are receptors will be relayed to the medullary cough symptom center. The cough center is in the medulla. Now the effector, شو الإيعاز اللي يجي عن طريق spinal motor, which is moving the expiratory muscles, and phrenic for the diaphragm, vagus for the larynx, trachea, and the bronchi. This is just refreshing your physiology and anatomy together. We said the major symptoms for the lower respiratory tract. First of all, cough. We have spoken about the cough. Now, the second major symptom of the lower respiratory tract is sputum. Correct? Ask the patient about the amount of the sputum. Very important. The character of the sputum. whether it is cirrus, mucoid, purulent, rusty، يعني بصدأ، لون الصدأ هيك pinkish like، right? So cirrus, it means watery like. And about the viscosity، لزوجة السبيوتم، viscosity، لزج، لين، solid، etc. Taste. Sometimes the sputum may get taste, and it will give you a clue for certain diseases. I will tell you example in a moment. The odor, the presence of solid material or blood with the sputum. And we will see the details in a moment. In asthma and allergic bronchopulmonary aspergillosis في حساسية ضد فنجس اسمها aspergillus. It's called the bronchopulmonary aspergillosis. The sputum will be viscid secretion، كثيف. Cuffed as worms، cast، شكل الورم، cast like. Now, if it is large amount, usually occurs in bronchiectasis. حكينا توسع في الحويصلات، البرونكيكتسس. فالسبيوتم يكون بكميات كبيرة، وحكيت أنه you have to encourage the patient to cough. In lung abscess also, a lot of sputum. If the abscess ruptured and the pus gets out, you will get a gush of sputum, purulent sputum, large amount of sputum. Large volume watery pink color, remember this, very important. It comes in emergency. Large amount, watery, pinkish in color. This is pulmonary edema. Very dangerous condition. يعني بالمناوبة راح تشوفوها إن شاء الله مستقبلا. يجي لك مريض تعبان ديسني كذا، تسأله على السبيوتم، يقول لك كميات كبيرة مثل المي بورف foaming pink in color, pulmonary edema. That is why I said history taking is very important. Yes, very important. Little amount and mucoid may indicate asthma. Less amount, less than this, it may occur in chronic bronchitis. A productive cough, it may lead to purulent productive cough. In pneumonia. A dry cough، يقول لك والله ما في بس cough. May indicate, especially in old, it may indicate lung cancer. Frothy, as I said, liquid pulmonary edema, as I described. Mucoid asthma, chronic bronchitis. Very thick COPD. تعرفوا شو COPD؟ chronic obstructive pulmonary disease. COPD يصير بالسموكرز. smokers 20 سنة يصير عنده COPD. and in chronic bronchitis. Rusty على لون الصدأ، pneumococcal pneumonia. Remember this, very important, a clue. If a patient, if history comes to you and say rusty sputum, what will be the most important microorganism, the causative agent? وأعطاك عدة microorganism, Streptococcus pneumoniae is the answer. Right? Rusty sputum. Causes of hemoptysis. It has been put in a symbol battle camp. B, bronchitis, bronchiectasis, aspergilloma, tumor, tuberculosis, lung abscess, emboli, pulmonary, coagulopathy, autoimmune disorder, IV malformation, alveolar hemorrhage, mitral stenosis. Remember, mitral stenosis may lead to hemoptysis and pneumonia. Just how to remember it. Because sometimes you need these words as a symbol just to, we call them mnemonic. مو mnemonic pneumonia, لا. Mnemonic للذاكرة يعني, okay? From name mnemonic. Now, intermittent hemoptysis may... نعم. Okay. Odor of sputum. رائحة السبيوتم. Foul smelling, رائحة كريهة. هو المريض بيجيك بيقول لك رائحة كريهة. أنت من تخش على المريض عنده كب مخليه عنده يمكن الرائحة واضحة أحيانا. So foul smelling may indicate anaerobic infection, bronchiectasis, lung abscess, empyema. Empyema, the presence of pus in the pleural cavity. Okay? Empyema, the presence of pus in the pleural cavity. Change of the taste of the sputum. يقول لك والله صار بطعم. Exacerbation of infection in case of bronchiectasis. The background for it. Watery, salty. بطعم الملح. Maybe ruptured hydatid cyst. انتوا تعرفوا الهايداتid cyst ممكن يصير باللنك. Ruptured hydatid cyst may give you salty taste with the skin grape-like material. يعني زي قشور العنب. Chest pain. Chest pain can be due to three main causes. From the cardiovascular, GI, from the respiratory. I will leave the cardiovascular and the GI to my colleague to speak about chest pain. But today you have to remember that respiratory tract diseases may cause chest pain. Just summary of the different conditions that can cause central chest pain. Central chest pain, مو peripheral. Central chest pain, aortic dissection, esophageal spasm or esophagitis, acute bronchitis, angina pectoris, الذبحة الصدرية, massive pulmonary embolism. These are the main causes for the central chest pain. Central chest pain, as I said, may occur from respiratory diseases like tracheitis or bronchitis. How I should know these are from this pain is from the respiratory tract? This pain is worse during cough. هذا هو اللي فرق. ولهذا السبب taking history from the patient is very important. It gives you the clue for the answer. Angina pain, angina pectoris, الذبحة الصدرية related to effort. والله دكتور من أطلع الدرج من أمشي سريع. هذه angina due to the heart. Pericardial pain. How I know in pericarditis the patient will have central chest pain? The patient will tell you, when I lean forward, أنحني لقدام، هو وقاعد ينحني لقدام، he will feel better. This is a good point in identifying what? Pericarditis, pericardial pain. Pleuritic chest pain, sharp stabbing، يقول لك دكتور زي الخنجر صدري، from the lateral side mainly, on the lateral side. Intensify by inspiration، من ياخذ نفس عميق يقول لك دكتور والله ما اقدر توجعني، تمام؟ Or coughing. Coughing will also increases the pain. You have to remember that pleuritic chest pain is not always related to the pleura. Maybe due to trauma, to the chest wall. Maybe due to herpes zoster، الحزام الناري اللي يصير along the dermatome على طول الأعصاب. سامعين بالحزام الناري، herpes zoster، درستكم الherpes zoster. The causes are the following. Lateral chest pain or pleuritic chest pain could be due to pneumonia, to trauma, blunt trauma, fracture of the rib and contusion of the muscles, herpes zoster, or nerve root compression. Now, remember the respiratory causes. These are the cough, breathlessness, chest tightness, or diffuse pain. بهالأمراض هذه واحد عنده chronic cough, breathlessness، ممكن يجي لك يقول لك والله عندي diffuse pain، يعني مو يحدده central أو lateral. يعني يقول لك صدري يوجعني، منين يوجعك صدرك؟ ما يقدر يحدد. Diffuse chest pain. Pancreas tumor, which I have said in the upper left lobe. Pancreas tumor is a tumor of the pulmonary apex. Mediastinal pain. في فرق ما بين الريسبيراتوري وفي الميدياستينال بين. الميدياستينال بين dull aching retrosternal، يقول لك تحت عظم القص كأنما عميق في صدره، which disturb sleep, may be due to cancer invading the mediastinal lymph nodes, or thymoma, tumor of the thymus. Shortness of breath, dyspnea. Usually normal breathing is unconscious maneuver. يعني انتوا هسه دا تتنفسوا ما واحد دا يفكر كيف دا يتنفس. المريض اللي عنده ديسنيا يحس أنه عنده ضيق نفس، يعني unexpected awareness، يصبح aware about his breathing، unpleasant feeling، يقول لك ما مرتاح دكتور. هاي هي الديسنيا، awareness و unpleasant feeling. Patient describe the dyspnea، ضيق النفس، difficulty in getting enough air. يقول لك دكتور والله ما أقدر أتنفس كويس، أحس نفسي مختنق، يعني يحس نفسه أنه ما يقدر يأخذ الهواء. هذه هي الديسنيا، هاي تعابير المرضى. Causes of dyspnea could be cardiac, could be respiratory, could be anemia. Remember, anemia as a cause of dyspnea, shortness of breath, sometimes psychological. واحد عنده HYS, hysteria يعني. شوفه يتنفس. You have to differentiate between all of these causes. What are the contributing factors to dyspnea? I will stop in 5 minutes and then give you rest. Now, I will stop in 5 minutes. Not now, please. Not now. هذا خلاص ماشي.
المرة حطيت الجهاز